Hi, and welcome back to the Trusted Messenger podcast. I am your co-host, Trusted Messenger Program VP of Comms and Strategy, Chad Herman, along with your other co-host,
Dr. Tobalin, Executive Director.
Episode 3, Todd, we are still here. The Nielsen ratings are high. They haven't canceled us yet. This is a good thing. We're going to keep it rolling. I realize now, before we get to our today's amazing guest, that we need to do, however, just a little bit of housekeeping that we've not done yet, but we need to. And that is, we need to acknowledge the composer, producer, and performer of our theme music, both our intro and our outro music. You can see Todd's getting a little verklempt because he may have a pre-existing relationship with that composer, producer, and performer. Todd, tell everybody out there who is the creative genius behind our theme music.
A big thank you to Zachary Woolen. I would just like to say all those music lessons paid off, and your royalties are still being paid in the form of leftovers that you come over and eat sometimes. So thank you.
And believe me, I have seen that young man eat leftovers. He is being well paid for his efforts here today. But again, yes, Zach Woolen, amazing, talented young kid. So Zach, thank you for your contributions to this show. All right, here we go. Episode 3, kicking off with a very special guest. Dr. Charlene Wong is a pediatrician and executive in residence, as you see by her subtitle, at the Common Health Coalition. Todd, I'm going to turn it over to you for a further introduction because you, speaking of housekeeping, are also one of our prime kind of talent scouts and booking agents for this show. And you said we have to have Charlene on. She's amazing. So I'll let you take it from here.
Yeah, Dr. Charlene Wong and I are this is about the amount of time we have known each other so far. Relatively new friend and colleague, but absolute rock star. And I'm going to let Dr. Wong introduce herself as far as where she's come from, her professional path, and then we'll jump into the topic of communication as we always do. Charlene, take it away.
Well, Chad and Todd, so wonderful to be here. Thank you for the invitation. I love that communication is at the center of everything because it's at the center of everything we do, in my opinion, as we are working to improve health. So, Todd, as you mentioned, and Chad, I am a pediatrician. I specialize in adolescent and young adult medicine. I have worked in academia, and most recently, I've spent 5 years in public service, working both at the state government level and most recently in the federal government. In state government in North Carolina, I helped run our COVID response. And then was in a position where basically my job was to do good things for kids and families across North Carolina. The role was called the Assistant Secretary for Children and Families. And it was a great honor to oversee and lead initiatives around everything from WIC and SNAP to our physical and behavioral health programs. I also oversaw our early care and education programs, early intervention. And so it was really a very unique and privileged position to serve in that role for kids and families across the state. And then I went to the Centers for Disease Control and Prevention, where I led several of our health strategy initiatives. And many of those really focused on how do we meet mission to protect health and improve lives by working in partnership. And we talked a lot about protecting health as a team sport, meaning that the team health can be very big and broad. And two very important players on that team are both public health and healthcare. So much of the work I did there was about forging relationships and really working tactically, collaboratively together on things like vaccines.
Yeah, first off, that is highly impressive track. I mean, pediatrics is tough enough when I think about it. Adolescence adds a little more flair, and then you throw in state and federal just leadership and initiatives and trying to conduct, as you said, a team to work collectively to improve kids' health is just amazing. And Charlene, as you know, as we've talked about, the whole focus of the show is communication. We have people from healthcare and public health that come on, people from outside of those realms. At the end, we always kind of want to tie it up. What can we learn to improve healthcare using communication? So my first question is going to be, first off, let's go back to the beginning. I imagine you had thousands of hours of training on your stethoscope, thousands of hours of training on your otoscope. How many hours of training did you get on your Communicascope, Charlene? Seriously, medical school, residency, even in experiences after that, if you had educational experiences.
I mean, I think minimal in the sense that any communications training during my clinical training program, so residency and fellowship, that was sort of called out as that. Now, I do think, to give credit where credit is due, we did have components of our clinical time, particularly I feel like in maybe like second year of med school, sort of going into clinicals, where we had, I forget what the course was called, but sort of like patient physician relationship, which certainly included a lot about, how do you communicate? Where in the room can you sit to make your patient feel more comfortable? How can you sort of work to build that rapport? Was built in. But I do think it probably in some ways was a little bit dependent on who you got as your preceptor, right, for these particular courses.
Was it like the Seinfeld episode with the mock patient, like Kramer played? I don't know if you saw that episode.
Not quite like that,
Okay.
but
Okay.
so I do want to give credit. There were pieces of that built in different places, and in my medical school, I feel like there were even times when sometimes we would be recorded having some of these conversations with the playback, so that and then there would be feedback, there would be role playing, and I think those things I think are very important. My sort of first more formal communications sort of I guess I'll call it training, is more when I moved into various leadership roles or started engaging with press. Then there were communications teams at the academic medical centers I worked at, or then when I went to the state, who were really, training me up, giving me like more concrete tools to use in thinking about communications. Primarily started first with media, what are your sort of key points? And actually, I did a fellowship at the CDC. I have to give them credit too. They had like a pretty prescriptive approach to doing communications. What are your top 3 points that you're trying to get across? Write it out, get it cleared so that you can make sure you keep coming back to that. But then I really want to give an immense amount of credit to the communications team and leadership at the North Carolina Department of Health and Human Services, because I was in a role working on the leadership team that was leading our COVID response. I mean, you talk about the importance of communication, and we did some things great in North Carolina. There are some things we could have improved. There are things that certainly public health as a field could have improved during the COVID response. And really the team there showed me what proactive strategic communications looked like. And I would say like one key lesson that I learned there that I have brought forward into everything I have done since is engage your communications friends early and often, right? Like I think, so often, and this was my experience before, the comms team gets brought in at the very end of the work, right? Because you're about to engage media, and then they're coming in to help, edit or refine your talking points. But instead flipping that and really bringing comms in on the front end and throughout the process.
I will say that's what Chad calls bringing in magic communication dust. Like after there's a dumpster fire, then communication is called, hey, can you just make that all better, please?
Yeah.
But the proactive nature of communication, absolutely.
I don't think you could see it because I'm smaller on the screen, but there were just tiny tears of joy coming out of both of my eyes, Charlene, when you were talking about the importance of bringing in the communication experts at the beginning to help create the foundation for everything that you need to talk about and how you're going to talk about it. So yes, amen, hallelujah.
I do want to point out the dichotomy, though, which is exactly what we hear again and again. If there's any training for healthcare communication, it tends to be this one-on-one with a mock patient, kind of working on how to take a good history and make a connection. Important, needs to be so much more, particularly given in the day and age that we live in right now. Second piece was about media preparedness and really communicating to a large swath of people, from either a public health official standpoint. The key and something, and we certainly want to jump into Common Health Coalition because as your trajectory is taking you there. But the key here that we always want to go back to is year upon year upon year, data continues to show that people, even in 2025, trust their healthcare provider. And so a key part of what Trusted Messenger program, based on a lot of our experience from our previous pediatric practice days, is how do we enhance that trust? Because in 2025, how do we help healthcare providers? What can we learn, particularly via this podcast, in bringing communication and all the health education and information that we have in a way that's compelling, that allows us to engage, to connect, to empathize, to use active listening, to build that kind of rapport, to not let somebody who has taken no oath to do no harm to steer our patients into harm's way sometimes. How can we be better communicators? And if you could take your path to Common Health Coalition from those previous points on your path and let us know where communication plays for Common Health Coalition, that'd be great.
Yeah. Well, I just have to say, I think that, what you just pointed out was such a focus of all the various positions I have sat in at the state. At CDC, we worked on that a lot because we knew that we needed to support clinicians who were on the front lines, particularly at that time, as, for example, we had new guidance and public health recommendations coming out around, for example, nirsevimab, the RSV immunization for babies. And we needed to get this information quickly to clinicians because this was a life-saving immunization for babies. And Todd, both of us as pediatricians, like anyone who's ever cared for a baby who is struggling to breathe with RSV, for which we have like no cure besides support, and wait for them to turn the corner, knows just how game-changing, right, this is.
Yeah, but that's a great, I want to stop for 1 minute, Charlene, because that's a great example, right? We have now new immunizations of monoclonal antibodies to prevent RSV. This is one that's absolutely super interesting because I don't see a huge resistance, right? We have two approaches that we're either immunizing moms during their third trimester, or we're giving infants, depending on the time of the season, if they're entering into RSV season, as quickly as possible, monoclonal antibody, single dose with long half-life that now gives them 6 months protection. The reason why I think that one is not facing so much pushback is because it feels real. You do not have to go past too many parents for them to have a friend who had a kid that went to the ER or was hospitalized, for sure a pediatrician. Like Chad and I we'd always talk about the one thing that scared the heck out of us pretty much every winter, and the thing that brought an ambulance to our office was RSV, right? But think of HPV, or think of measles, or think of COVID, right? The kind of things like, I don't know what it looks like. I'm not familiar. It hasn't had a bunch of inaccurate information thrown at it. And so then it allows people to play with the facts or the science. Whereas RSV, I think, is so visceral for parents, like, oh my gosh, my niece was hospitalized for 2 weeks. Like, what about that? Like things you took on in CDC or in Common Health Coalition that's visceral and real, it's not as hard to bring people on board, right?
I think it's not as hard. I agree with you. Not as hard to bring people on board. And we as clinicians, particularly primary care physicians and clinical teams, we're just asked to know and cover a lot, right? And there's always new stuff coming out. So I would say in part of our lens into this work was this just got recommended right before the season that it's supposed to be available to babies. And so, we didn't have a long runway to sort of, use all the multi-channel messaging sort of platforms that we have. It was like, it's recommended and now's the time to immunize, because if we don't do it now, you miss the opportunity, right?
Yeah.
This is a seasonal virus. And so really our focus was on what are the key messages? How can we most quickly disseminate those messages effectively and repeatedly to the people who most need it? Because again, there's so much that we're supposed to keep up on, right? And what we're supposed to go over in a well child visit. And so, we really worked closely, for example, with the American Academy of Pediatrics, the American Academy of Family Physicians. We worked with the nursing organizations. We worked with the pharmacists who were doing a lot of the maternal RSV immunizations. So there's all these different parties, right, that need to be engaged. And, fortunately, we've been working to forge some of these relationships, right, because good communication is built on relationships and trust. And so being able to do that, but then importantly for the message, also distilling it down to as like simple as possible. What do our clinician colleagues who are on the front lines having these conversations, what do they really need to know? And what we were often hearing from clinicians is like, give us example words, right? Like give us the example words we can be using, because like I'm already being asked to think through and do clinical decision making on all these other pieces, like any piece of that like cognitive load that you can take off my plate and just hand to me. And then certainly I'll adapt it, right, for the patient sitting in front of me, at least so that like I'm not having to like, you're giving me evidence-based, fact-based, words to use. And then finally, we thought a lot also about other maybe non-traditional dissemination channels, because it's got to be easy and it's ideally in the workflow. So I really want to give kudos to some of the what we called clinical workflow partners that we were working with. Epic and some of the other EHR vendors were amazing. We were working with UpToDate, because you think about, like, I think about what screens do I have open in my clinic. I've got my EHR open. I sometimes will have a browser open that's like up on UpToDate. I know a lot of people use Open Evidence now. Certainly people are even just using Google. And we were working with some of these partners because, again, this was changing quite rapidly, to make sure that we were feeding, the best sort of most recent recommendations and evidence and sort of talking points to them. And then they were doing the work to build it in where it made sense in their platforms, so that, again, like these things were just built into the workflows for clinicians.
So all the pieces that you're talking about there, all the different ways to really distill the information, to think in a comprehensive fashion. But ultimately, at the end of the day, as you said, it's to get it into the hands of healthcare providers that serve patients. You made a great point of illustrating that healthcare providers can be pharmacists, they can be nurses, they can be nurse practitioners, physician assistants, midwives, right? Anybody that's in a position of service to patients where those patients are looking in a trusted way with a built-in relationship to, hey, what do I do or what do you recommend? In 2025, again, the data continues to be unequivocal. People want to hear from their healthcare provider. School nurse, like I said, clinical social worker, anybody who's in that role needs to be empowered with better communication. And so while you were doing it at the state and the federal level, what I sadly am seeing is that healthcare providers themselves are not trained in their schooling, nor their training programs or their residencies, and definitely not in their professional paths. They're not trained. They're not resourced. They're not supported. They're not positioned. And also you talked about, a multimodal way to engage, right? Think about it. We're still trained in, for instance, medical schools and residencies as if the only place that important communication is going to occur is face-to-face with that mock patient, right? It's 2025. It's really hard to get an appointment with your healthcare provider. So if you are banking on, somebody's going to save their 5 questions up to see you in 3.5 months, it's insane. You are, this age, and this is not just millennials and Zers and Xers, everybody, boomers. If I want an answer to a question, I am on my phone right then and there. And here's a gap where I think we miss again the mark. While that time is precious face-to-face in the exam room, and we have to be better at it, we are not really trained, particularly when we come up against somebody who's been impacted by inaccurate information, right? Because healthcare providers are pretty conflict averse, which is why we're seeing that they say, I'm feeling harassed, I'm feeling targeted, I'm feeling rushed, got to generate more RVUs, and now I have to have a long discussion. Oh my gosh, no, right? Which is big part about what the Trusted Messenger program is. How do you go into that room, have an evidence-based communication pathway that allows you to stand by the evidence, but still empathize, use active listening, and leave that interaction, even if the person doesn't accept your recommendation, with more trust, right? So the piece that you're bringing up is all this excellent information being distilled and made as accurate and as usable as possible for healthcare providers. But I still think we have these misconnects with how do they ultimately get this information in the hands of their patients. At Kids Plus, at our old practice, we used that face-to-face time, but it was then further cemented with social, an up-to-date navigable website, podcasts, live streams, like, again, meeting people where they're at. And that included virtually as well. So with all this pathway taking you to better communication, evidence-based practices, and protecting people's health.
Todd, before we go any further, I don't want to leave a point behind that I think is really important.
Yeah.
we've talked about this before. We talked about it in the work that we do, but that workflow that Charlene was talking about is so critically important, right? Even at the level of the CDC, it's how do we get the talking points? How do we get the messaging? How do we get the information into the hands of the frontline healthcare providers? Because that's where the trust lies, because that trust is local. That is so critically important. And we're recording this episode in mid-December of 2025, when there is less trust in the CDC than there was a few months or certainly a year ago. One of the things that we keep telling folks is, while we're obviously not happy about that, it's not as much of a dumpster fire in terms of the actual patients that we're seeing or that you all are seeing, because, and we always ask people, how many times in your career have you made a recommendation to a patient and their initial response was, is that what the CDC recommends also? It's not. Never. We've not heard one person say yes to that. What they care about is that my healthcare provider in that exam room, who I trust, made the recommendation. And so that's why, whether we have high levels of trust in the CDC or we have less now because of politicization, the important thing is still getting those messages and that good information in the hands and the mouths, and to your point, Todd, the websites and the social media pages of the healthcare providers, because that's where it's going to have the best chance of making a difference in patients, families, communities.
Yeah, I mean, it's, again, the multimodal approach, but ultimately getting into that relationship with healthcare provider and patient and family. So Charlene,
Yep.
what I was wondering is, so your path then has now taken you into this role, into the Common Health Coalition. Can you tell us a little bit about it? And can you also tell us your role? And also, again, obviously with the lens of communication, how is this playing out there? What does the organization do, and what do you do there?
So the Common Health Coalition just celebrated its second anniversary, and it's an organization that was founded by a set of founding members that are in healthcare. So the American Medical Association, Hospital Association, the two big payer health insurance organizations, and Kaiser Permanente. And those organizations came together to say, wow, look at what we were able to do during COVID, when we really worked very closely, hand in hand, alongside public health. Again, some things that went well, some things that we learned along the way. And there were some gaps, and there was like a lot of light shining through those gaps sometimes, but, worked hard, and because we had to, right? We had to figure out how to work together very quickly. And so really these organizations came together to say, we've got to continue working in that way, public health, healthcare alongside each other. Again, we have such shared mission around protecting health, improving health and well-being. And so the Common Health Coalition has really existed to do just that. In this moment, much of the work of the Common Health Coalition has turned towards, again, how can these partnerships really continue to accelerate how we're able to and grow the impact of how we're able to protect health in this moment, when there is a lot of shifting policy, both on the public health and the healthcare sides of the team health team here. And so, for example, a lot of the work that I've done in my role as executive in residence has been focused on how do we protect access to vaccinations in this moment where there are many federal shifts in vaccine policy have either already, had a clear, very tactical impact on access to vaccines, and or thinking about communications has led to confusion, both on the part of providers as well as patients and the public. And so our work has really been in that space to work with multiple partners who are also working towards that same goal of protecting access to vaccinations. And our particular role has been to move nimbly to connect the dots across evidence, and then policy to practice. And obviously that policy to practice piece is everything that you guys keep hitting on with TMP.
So for Common Health Coalition, the way that it would ultimately impact providers ultimately would be through integrated delivery networks, through hospital systems, health systems, through insurers, through public health entities as well, ultimately kind of trying to build consensus, connect dots, and make the messaging easier. Is that correct? I mean, I don't want to put words into your mouth.
Yeah, there's a couple of things, right? So, the evidence piece is, what does the evidence, right? What does science say about what recommendations would be best for protecting health? And then that science, that evidence then needs to be translated into if policy changes, for example, are needed. Maybe we've seen a lot of changes at the state level and states taking action to protect access to vaccines. We've seen health insurance companies, we've seen health systems taking different actions in their policies to protect access to vaccines for their communities, for their patients. And then those policies then need to also get translated. So those of us on the front lines who are having these conversations, like, know what it means for us. So I'll give you like two examples. And I know one of these is one we want to delve into quite a bit more. When the recommendation for the 25-26 updated COVID-19 vaccine shifted to shared clinical decision-making by the Advisory Committee on Immunization Practices, we were working with, again, a variety of partners that we had already been meeting with. So we had that trust, we had that relationship to say, we think we're hearing that clinicians might need support. They may need tools, right, to understand like what exactly this means, what they need to document, how to do this, are they already doing it, things like that. And so we created a clinician-facing tool with multiple partners very quickly because that recommendation came out and immediately people were asking questions. So that's one example. And then a second example of a clinical practice tool is, again, for the COVID-19 vaccine. In past years, the CDC has created, I call it like a visual dosing guide so that, our clinical teams in practice know if it's like the teal vial or the gray vial or, the red one, depending on what age and which vaccine you're using. This year during the government shutdown, that just was not created coming out of CDC. And while the American Academy of Pediatrics had created one for children, there just wasn't an entity that was in a good position to quickly create one for adult COVID-19 dosing. And so we, again, worked very quickly with multiple public health and healthcare partners. I also want to give credit to the AAP who said, hey, use anything and everything from our dosing guide that you can just copy and paste over, because a lot of it was still relevant for adults. So that's just like another example where, it's like they seem like they're very small and get used heavily, right, across the country because, these clinical teams, everyone's trying to keep up with, well, what changed? I need to print this one out because there were some changes from the dosing guide from last year because it was a different, it's an updated dose and things like that. So,
no, I finding North Stars is one of the things now that we're hearing from healthcare providers that we just used to always point there, right? And when you have an entity like CDC that is now made and HHS, which has made somewhat of created a divergent path away from evidence-based protocols towards some more opinion-based protocols. It's created a lot of concern, right? Because it was easy just to always point your browsers or links toward one direction. As a result, we've seen AAP, ACOG, other entities saying, we aren't diverging. We're going to continue to follow the same decades-long path of using evidence-based policies to create guidelines, right? I know it's part of the reason the nonprofit Trusted Messenger program is part of Public Good Projects is so thrilled working with the Common Health Coalition that, using communication evidence-based protocols is key. It's what we as healthcare providers want and need to help guide our patients. And it's gotten trickier out there, Charlene. It
has gotten trickier. And that's why, this shared clinical decision-making guide, we tried to keep it as simple as possible, including what we were hearing, because you just can't find it online. Again, what are the different options for words that I can be using, right? Because there's a lot of different ways to do it, actually, and many of us are already doing it. But people just weren't sure, right? Is what I'm doing, does it count? Do I have to document something differently?
Well, and count, to be clear, for the people watching this that may not be down in that level, when she's talking about shared clinical decision making, it's a pivot point on documentation that leads to coding, that leads to billing, that either gets you paid or doesn't, which is a critical piece in remaining solvent as a practice, right? And that like you're saying, these little pivots from a policy standpoint started throwing major wrenches in the system for a healthcare provider and an administrator to figure out, like, does this still count? Like you said, like that was on the fly in the midst of everything that's going on. Is, wait, I still have to see the patient, do a differential diagnosis, come up with a plan, but will this count now because changes are being made to the actual process to see and then bill and code for the patient?
Yeah. No, and I think just again to back up, because thanks, Todd, for saying that, just to make sure we're all on the same page here. Shared clinical decision making is a type of recommendation that's relatively newer that used in our country for vaccinations. And really simply what it means is that this is clinical counseling between a patient and a clinician about the benefits and risks of vaccination. Like I said earlier, there are so many different ways to do a shared clinical decision-making counseling between a patient and a provider. And almost all of us are already doing it because, of course, we are all having conversations with patients or with the families of children to say, okay, hey, here's a vaccination that's recommended for your child at this age. Here are some benefits, here's some risks, or even like, what questions do you have? Because often families have done reading and, if there are more wonderful resources out there for them to help give them good information as they're even coming into appointment, because there is a lot that we are asked to cover, for example, in a well child visit, even better. But then, it's always, and we always give the option on our teams, do you have any questions? And we make ourselves available to answer those questions. So there's like many ways to do it. It can be short or long. It can be synchronous, meaning, at a visit, or it can be asynchronous. Maybe some of it's happening through your MyChart or over the phone, before an actual appointment. It can be happening in multiple locations. We're certainly hearing the way some pharmacies are implementing this is, using their electronic scheduling system. And then, of course, again, always whoever the vaccinating pharmacist is providing, again, always opportunities to ask more questions. So lots of different clinicians can be involved. And then we've got, this conversation guide that shows like it can be so short as, this is a recommended vaccine. What do you think? Do you have any questions? To a much longer conversation that goes back and forth around, what are I hear that you're having some concerns or you have some questions, help me understand, like what's a main concern that we can start with? And then, going through one by one.
Right. And to your point, and you said it, we were already doing counseling. Counseling codes came years and years ago. But the shift from a governmental standpoint as to labeling, as to what was recommended versus what was recommended via, shared decision making, kind of threw some of these wrenches and muddied the waters in many ways. What we see happening in healthcare right now, right, I think is from the policy level, from the very top now down, is a muddying of the waters. Like hepatitis B vaccination for infants. Absolutely, unequivocally clear. We started trying to give it to high-risk groups. That didn't really work. We got to a universal recommendation, which then kind of takes out, like, it's in some ways very different than, you need shared decision-making to see who gets this, because it was universal, right? Which means you still counseled, but everybody should get it. And as a result, we knocked out hepatitis B in close to a generation's or plus worth of kids who became adults, right? We're now going back without using evidence, right? This is opinionated policy saying, well, why don't we just figure out who's really at risk? Is it people that are drug users, people like, and lots, and is it only moms that were positive because we can screen for that, which again, 15% of moms don't get the screening or the screening is not accurate. We have all this data. And so again, communicating these points becomes so challenging. And so I love that Common Health Coalition is building consensus across key stakeholders. And then, as you said, now trying to then make certain it's delivered in distilled, accurate fashion to the practices and the providers that do it. I mean, do you see I guess a trajectory for Common Health Coalition in how to handle these increasingly challenging times with more policy changes probably coming our way?
Yeah, no, for sure. And just to close it out on the shared clinical decision making, I think just two operational points I'd love to make sure that the listening audience hears here. One, because you did bring up payment and money makes the world go round. Vaccines that are recommended with shared clinical decision making are still required to be covered by health insurance. And I just want to make sure that that gets said like very loud and clear. That is still in statute. And so for patients, for providers who might be listening, any of these vaccines like COVID or hepatitis B, Todd, that you were just mentioning for newborns, still required to be covered with no cost sharing, right? So patients shouldn't have to pay out of pocket for them. And for documentation, I just want to point to some of the Common Health Coalition tools that we created with the American Academy of Pediatrics, the pharmacists, because there is some templated language there that can be copied and pasted for any clinicians out there who are thinking, what do I need to document? But I think exactly what you were saying is the case. While, in like function, it doesn't actually change really the way that our clinical interactions are already happening. It does, as you said, muddy the waters. A couple of things, just again, to bring some past evidence forward, because there are other vaccinations that have been recommended for shared clinical decision-making, like HPV vaccine for some adults, the meningococcal B vaccine for some age groups. It does, we have already heard that there are both providers and patients who perceive this as being, is this more of an optional vaccine? Is this a vaccine where maybe like it doesn't work as well, or maybe there's more questions about the safety? So that's why there was a change, right? Because whenever people read a headline that something's changed, immediately, of course, we go to, well, I wonder why that changed.
Yeah.
And so when it goes from the routine, like you mentioned, to shared clinical decision-making, that's certainly something we heard. And again, looking back at some past studies of providers for some of these other vaccines that were recommended as shared clinical decision-making, including for pediatricians, like over half were saying, I don't really have a good approach to explaining this type of recommendation to patients. I have questions and I wonder, and I'm not confident about some of the things like payment. And doctors, we're just like everyone else, right? When you lack confidence in something, you're just more likely not to do it because you're not 100% sure. We have our plates very full, of course, already with the number of things we're trying to do. So I think that's really important. And so, when we think about creating tools like this, and that we continue to update and iterate, right? Because when we do that based on what we're hearing from our partners, and this gets to your direct question, Todd, is, where do we see things moving forward, right? This is a moment, because things are shifting, because there are many groups that are actually really working hard with certainly inadequate resources to do the things, because we all feel very deeply that it is our mission to protect and try to improve the public's health, our patients' health, right? That type of partnership and the critical importance of having routine communications internally, right, amongst team health, so that and so much of that needs to be listening to the partners who have the closest ear to the ground, right? Like what sorts of questions are we hearing from patients? What sorts of concerns and questions are we hearing from providers? I'll give you one that was not at the top of my list. Was all these providers were worried about liability because, now that this recommendation has changed, if I don't document the right thing and say there is one of these rare, bad, adverse events from a vaccination, how much am I at risk personally, right, on my medical license because of that happening? Because I don't really understand what's happening with all of these other liability protections. And so, again, at Common Health Coalition, we worked very quickly with some of our internal lawyers that we had. And then also, again, working with multiple other partners, everyone was asking the same questions, right? And it was like, how can we work on those same questions together so that we can be aligned and quicker to what the answer is? Because every time we put out anything, even that's just a little bit different, that just breeds more confusion and potentially lack of confidence in the vaccines and what we all know will work. So, I think that continues to be a key role for the Common Health Coalition, is building, sustaining those partnerships so that we can move together in connecting those dots of evidence to policy to practice.
One of the things we're trying to do with this show, Charlene, obviously, is you talked about them earlier, some of those sort of practical nuggets or pieces of advice for the folks who are on the front lines from communication. So I'll ask for sort of two, in the time that we have left, two shorter answers. You talked earlier about lots of gaps and learning lessons and mistakes that were made. So maybe first, if you could share something that you would urge the healthcare providers out there on the front lines to be wary of, or to not fall into a type of behavior or communication that you might have seen folks make mistakes. And then finally, what's one good practical nugget they can put in their toolkit to improve their communication with their patients?
All right, two short answers back, Chad. I love those questions. So for the first, I think now the evidence is also pretty resoundingly showing that for many patients, using the line that I was trained on in medical school of vaccines are safe and effective. This is,
Great one.
this is like
Absolutely.
this is not the thing. But to your point, I mean, like maybe we did get training on that. Who's updating, right? Who's updating the training? And frankly, I have seen changes in my practice over the last 6 months, right? The sorts of questions I'm getting. And so I think that, Chad, to be tight, that's the thing to avoid, just falling back on vaccines are safe and effective. And then
and it's hard, right? Because it's muscle memory, right? It's a phrase that people have used for a very long time that sounds good and is, of course, accurate. But yeah, it's something that is now sort of a hot button or a trigger. And it's a good thing to move away from. Love that.
Okay. And then the second one, I have a totally different kind of answer, which is that one area that I think all of us, particularly those of us who serve children, and because so much of, we've talked a lot about vaccines and a lot of the rhetoric and changes are happening in childhood immunization, we should go back to why are we all doing this in the first place? It's for the children. It's for their health. And we should be listening to kids' voices also, right? And I will just make a quick plug. I'm part of a founding team for a new organization called Seen and Heard, because while there is that old trope that children should be seen but not heard, we disagree. We think children should be seen and heard. We also think they should actually be a priority in this country. So when we as providers are faced with, days that can feel really tough, family interactions that can feel really challenging, let's go back to the kids. And I challenge all of us, and especially those of us who have the opportunity to be on platforms like this. How can we be bringing youth voices into these conversations? We actually recently made a video with Seen and Heard, which we're still finishing, but we were asking kids down from age 5, 6, all the way up through adolescence and young adulthood, why do you get your vaccines? How would you feel if you weren't able to get your vaccines? And let me tell you, powerful stuff. I get even a 5-year-old was like, I get my vaccines because I don't want to have to go to the hospital for medical care. I don't want to not be able to see my friends at school if I'm sick. And then, a little bit older kids saying, if I couldn't take my vaccines, I would be really angry because I want to live my life and do the things I want to do. And, I think going back to the source again of why are we doing this? Why did some of us go into the field of pediatrics? Any of us who are allies to the field of children's health, let's go back to that source.
That's great.
Love it.
I don't think I could say that any better, man. That's awesome. That's great work. I just want to give you a huge thanks for joining the show. I'll let Chad take us back out, but thank you so much. This has been wonderful, and I know we'll be speaking a lot more as well.
Thank you so much. It's been a total pleasure.
Absolutely. Thank you for being our guest. And as we're getting used to telling folks who are on the show, thank you particularly for the incredible work that you are doing to protect children, families, whole communities. Dr. Charlene Wong, again, pediatrician, executive in residence at the Common Health Coalition. Thanks for being part of the Trusted Messenger podcast. And thank you all for joining us as well. We will see you next week, as always, with a new episode in which we are talking about how we can use communication to protect, as we were just saying, public health and the lives of the children, the families, the communities that we all serve. We will see you next time.